I think now we can start now. Yeah, please go ahead.
Okay, sir. So, good evening, one and all present here. Actually, it's a very great opportunity to meet one of the great scientist as well as a researcher, like who is working as a genetic counselor and consultant in core diagnostics. She has pursued a BSc in genetics, followed by MSc in human genetics, and then she has joined in core diagnostics as level 1 genetic counselor. She has been perfect professionalist who has been working in this particular field, and her major area of interest include the specifically to dissect how genetic counseling can work in treating the cancer patients. So, without wasting much of time, I shall request Ruchi ma'am to take over the session, ma'am, and followed by we will be having short question answer sessions. So, ma'am, can you start over?
Good evening, everyone, and thank you, Indrani, for such a nice introduction. Okay,
Thank you, ma'am.
coming quickly
Thank
to
you.
the point, I have been a board certified genetic counselor for more than 8 years now, and I've been working with the cancer genetics field, with the clinicians, with the patients, with researchers for quite longer time, and I pursue genetic counseling in a clinical setup, in a telegenetic setup for the people who have lesser access to the genetic counseling services in their cities or anywhere else. And I also offer services at NGO for the people who can really not afford genetic testing or counseling as free of cost. So, quickly starting the session, I'm sharing my screen and we will be discussing today, or maybe more of an interactive session, where what is the role of genetic counseling in a cancer clinic, like how a genetic counseling works in cancer clinic, and what are the different scenarios and what look into, and a lots of things. Okay, so firstly, what is the genetic counseling? Defining a communication process which deals with human problems associated with occurrence or risk of occurrence of a genetic disorder in the family. This is a generalized definition for genetic counseling applied through variety of the field where genetic counseling is applicable. Most of the families are referred to genetic counseling either by the family doctor or a specialist. This remains the most common thing across the globe, that the reference to the genetic counseling at different point of their consultation comes through their family doctor or any specialization where they look into some disorder suspecting a genetic probability. Specialty of genetic counselor. Now genetic counselor is not a generalized role. Okay, you can have genetic counselor and you can have specialization or experience or your matter of interest in serving the different field, and it comes with your routine work or the interest or the training that you have undergone for longer period of time. There can be a cancer genetic counselor, a prenatal counselor who is expert into dealing with the NIPTs, PGTs, IVF cases, pregnancy or gynecological related cases which involves genetic mutations or any genetic disorders. Cardiovascular cases focusing specially on heart related conditions anywhere and everywhere where inheritance is related. Pediatric counseling covering most of the cases related with the pediatrics, chromosomal abnormalities, syndromes, developmental delays, missing of milestones, and anything. Neurology, the section where the person specially deals with neurological condition or a psychological condition which has got the genetic influence or a familial inheritance or any similar relativity. Metabolic disorders are special cases where most of the rare genetic disorders comes into the focus, and there are the counselors or specialties who specially deal on focusing rare genetic disorders associated with metabolism. Pharmacogenomics, the one who looks only after the pharmacogenomic cases where how medicine interrupts with the genetics and how it is important or beneficial for the patient, and how to go a patient centric or clinician centric approach covers all the pharmacogenomics. Then there is a very much emerging branch, you can say, of personal genomics now, where the people are trying to relate their health, diet, exercise, sports, everything with the type of genetic benefits they have, and seeing the progress of their health or weight management based upon their genetic qualities and following the genotype phenotype correlations of the healthy lifestyle practice. So these are the most major genetic counseling branch where you will find the where you will find the counselors pan India, and there are lots of diagnostic companies who also deal in the same profession, who hires the counselor for their counseling purpose, for patient, for clinician, medical science liaison. So it is like a one person having multiple roles and multiple specialties. Like, it is not like if a person is doing a cancer genetic counselor, he cannot do prenatal or personal genomics. The area of expertise decides where you want to work, and mostly we as a counselor decides where we want to work. Like, it's a clinic oriented, it's a direct to consumer product oriented. So professional choices depends upon the individual, but speciality is overall. Like, you can consult any counselor for any kind of counseling, and there is no restriction in that. How does the genetic counseling process works? Like, first process is to comprehend the medical facts, including diagnosis, course of probable course of disease management. Firstly is to gather the information, facts, and the papers what the previous workup have done. Then inform about the age of onset, mode of inheritance, explain about what is penetrance, what is expressivity, answering their questions regarding to that. When was the first individual in the family diagnosed? Or are you sure about this diagnosis? Do you have any documentation? Collecting the proofs and documenting it is very important process, because that will help us to recognize the way the hereditary contributes to the disease and risk of recurrence. Like, with this information, we form a complete pedigree workup, and then we correlate whether this cancer is on basis on the age of onset and their histopathology and their habits in the routine does clinically correlate with the inheritance factor, or it is a sporadic case. Then we talk about what type of genetic testing options they have and what are the potential results and implications. What genetic tests you can offer, what the results will tell you, etc. Then comes the course of action appropriate in the view of risk, family economic status, ethical and religious standards. Now, this is a very important part where the counselors, mostly focus. Like, it is not like just giving or writing a test, it is to understand how the individuals or a family's economic background is, what can be done to accommodate this genetic services which is required or mandatory into their economic structure. How are they going to deal with this condition? Are the results really beneficial? What will be they will be doing if they have to go another genetic testing post this test? How it is going to affect their social status, mental status? Does revealing of the information in the family matches with their ethics and backgrounds and religious beliefs and all? Everything has to be taken care in the entire process. Then is the family communication, education, and psychological support. Not every individual will be fine enough to comprehend the information with the genetic testing reveals. And we need to educate them what we need to process, what is important, what things need to be focused, and what is to be taken care of while doing the counselings. Then comes how the genetic counseling works in the cancer clinic. There are three different steps of genetic counseling in a cancer clinic. First is the pre-test counseling, where information gathering, making them understanding about the test, why it is important, what will you get. Then comes which test is appropriate out of all, because there will be lots of option available for genetic testing. What test to order in benefit of the patient, and what are the outcome which we desire after genetic testing. So what type of test is to be ordered is correlated with what kind of desires are we having after a genetic test. Are we looking for the therapy? Are we looking for the inheritance? Are we just looking for the career status checkup and all that? Then comes a post-test counseling where the results are disclosed. How are you going to disclose a potential result to the patient? How is patient going to react? What are the factors which you need to consider while releasing the report? What are the important points that a post-counseling session has to include? So overall, three step. One is and most commonly you will come across the diagnostic companies talking about two things. Like, we do a pre-test counseling, we also do a post-test counseling. Okay, and it is not a process or a process or a matter of 1 or 2 hours. It takes really sometimes a days, where we are not supposed to tell patient that after pre-test you are just going to do this test. We have to give them some time, and we have to give them some time span to understand and to decide, and gather economic factors also, because the tests are not inexpensive, they are very much costing a fortune sometimes. So this is the long process, which may take from few days to a week also, or a 2 to 3 week, depending upon the need of the patient. Points to focus in pre-test counseling. We need to evaluate patients' need and knowledge and concerns regarding the genetic test, benefits and risk implication. Firstly, to understand the patient is very important. So mostly in the pre-test counseling, lot of the time of counselor goes in the listening. All we have to do is to listen. We have to listen how much patient understand, what is the idea about the patient, and what he will do once he get the genetic test. So listening is the important, or you can say 50% part of the pre-test counseling, is to collect the detailed personal cancer history. Now, if I am doing a counseling to a patient, I have to understand what is the cancer history, कब diagnosed हुआ था सबसे पहले, when did you felt it, when was the diagnosis done, when was the testing done, have you done any testing before, do you have any hands on the report. Then we need to educate the patient on penetrance, heterozygosity, and inheritance. Like how much gene penetrance occurs, expressivity and penetrance कैसे related है, heterozygous, homozygous क्या है, what are the factors will a heterozygous inherit, what are the factors a homozygous inherit, how much percentage inheritance will be there in the children, and a long discussion. Then possible outcome of the reports and management, like enhanced surveillance, risk reduction surgeries, therapies. This depends upon individual to individual. Agar patient hai looking out for the therapy, then more time or the focus is on what kind of therapy options are available. Targeted therapy hai, to how this targeted therapy actually works, how it is different from the chemotherapy, what are the benefits, what are the economic factors stick along, what are the chances that your therapy will fail, what are the chances that the resistance will be acquired. Everything has to be explained to the patient, nothing has to be left out, even if you feel that you are not doing a justice, but these are the things patients should know. And the main work of the counselor is to explain them the potential positive, negative, beneficial, non-beneficial things about the genetic testing. I know that will not work in the favor of any diagnostic company working out here, but that is how practicing of genetic counseling is done. Disclose about the cost of genetic testing, documentation of consent, and inclusion of family members to its report disclosure. Now, cost revealing is very much important. How much is the cost? Will your insurance cover in that? What kind of insurance you have? You have to ask your insurance provider how much cost will be covered, included, not included. That clarity has to be done, because living in the Indian scenario, where I say that genetic testing is not affordable by a lot of people. So this clarification on this point is very much important. Second most important, considering the social and the cultural value of India, is whether to include family members in their report discussion or not. Because sometimes I will need an entire family to do a counseling. Sometimes the patient will be like, no, I don't want to disclose. I will understand and I will disclose it myself. So that is the point where you will not disclose anything. Sometimes patient gives the consent that report has to be sent to me directly and not to the clinician also. So we have to consider their request also upon, because they don't want to compromise with their privacy, or sometimes they are just afraid to, share it with other people on an instant, especially to the doctors also. Second is provide overview of current legislations about the genetic discrimination and the injustice involved along with the genetic testing information. Firstly, no one can discriminate you for any kind of a job or a work if you are having a cancer and you are not able to put up more hours. That should not be the reason to terminate you. Genetic discrimination, which is mostly done in the cases where a patient harbors a positive mutation and they are rejected from the job, telling that you are being at a risk of this condition and we don't want to compromise our employment on this, you shall not be hired. This is most common, not common in India, but it is most common in US and UK. But as a counselor, I educate them on the laws also, that these are their laws. Like you have the benefits of challenging the people if they discriminate you based on your genetic reports. Second is consideration of the most appropriate test. Now, when it comes to order the test, it is very confusing. What to do? Somatic, germline? Should I do liquid biopsy? Will that be good? Single gene will be sufficient. Which multi-panel should I go? Should I do a hotspot testing? So this all information we explain them. Like if I have a patient with the prostate cancer coming into my clinic and he's looking out for a probable therapy options because he's a metastatic castrate resistant, then I would advise him to go for the somatic testing because it will give him the advice like agar he's eligible for any targeted therapy, then that is done. If there is any tissue specific testing, like for example in cases of head and neck cancer, lung cancer, we don't go for germline testing. It is mostly a somatic tissue testing because most of the case commonly coming up in clinic are the smoking. Second is the germline testing. Now, when to do germline testing and for whom? Germline testing is generally advised in the cases where the age of patient is under 50 years with known or unknown family history. Mostly it is done for the diagnosis as first level, whether the genetics is involved in this cancer or not. Second is the risk assessment. Like for example, if someone comes with a blur information कि नहीं मेरी family में कुछ cancer था and this particular gene or that particular gene is mutated and I want to get myself checked, then you go for a germline testing because this is an asymptomatic individual and you are doing a risk assessment. Then comes liquid biopsy, generally done in cases of early metastasis where you have the PET scan which shows multiple lesions but unresectable tumors hote hai. You cannot get a biopsy or a core biopsy done. In that cases, liquid biopsy is preferred. Places where you are going to check minimal residual disease in the cases of leukemias or any kind of blood cancers, early metastasis, if you want to check, then also you can go for liquid biopsy. So it is chosen post therapies mostly. Okay, liquid biopsy is not for the diagnostic purpose. It is not for primary diagnosis. Okay, it is just a companion to your routine diagnostics. Like it is a secondary to the genetic testing based on tissue, but not a sole thing which can help you out. Then comes single gene testing. You check for the single gene when you know there is only one gene involved in the disease. Confirmation of the variant agar karna hai, for example, if someone has run an NGS and you are having a doubt that coverage come hai and I want to just confirm a variant, then you go for a single gene testing, which is usually Sanger sequencing based. Then is a multi-panel gene testing, where this is the most common testing most of the oncologists use, and usually we suggest them. Multi-gene panel testing works both in the somatic as well as germline setup. Genes specific to the cancer type are checked, and are the genes which are to be checked are mostly recommended by NCCN or ESCO guidelines. For example, in a case of CA ovarian cancer, we generally prefer going for an HRR panel like homologous recombinant deficiency. And simultaneously, we also go for an HRD testing, which is a multi-panel testing. So depending upon what is the eligibility, and again, the economic structure here is very important. We suggest the multi-gene panel because multi-gene panel comes as inexpensive as 25,000 to as expensive as 3 lakh rupees. So all the factors have to be considered before suggesting a multi-panel. And what will be the exact utility? Because if you're spending so much of money, what are you going to get out of it? What kind of biomarkers will be covered in that? How much coverage will be given? What information I'll be getting? Will it be included with the Sanger confirmation or not? So lots of things are involved in multi-gene panel testing. Then comes the hotspot testing. Hotspot testing mostly done in the cases where the person is suspected of only certain gene mutation based on the histopathology. Very less used, and you can say it is mostly used in the rural or government setup where the patients are totally unaffording. Like they cannot even afford getting a test for 3 to 4,000 rupees. In that case, hotspot testing is used because it covers all the known mutations and you get an instant answer. It's a PCR based and very easily available. So for the people who cannot afford the full gene sequencing or expensive testing, hotspot testing is still used by doctors so that they don't get left out of their eligibility of getting the testing and the treatment. Then, what are the points to consider in post-test? Now, we have done we have done a pre-test counseling. We know the diagnosis, we know the history, we know the pedigree. Now comes after the test revealing of the reports. How are you going to break the good and bad news? Now this is very much important. When I'm doing a cancer counseling in clinic, it becomes easier for me to break the news because I can sense what the patient is having a vibe of, what is the patient feeling, how am I supposed to start the conversation and lead it to the revealing of the news. But while doing a genetic counseling session over the call, we have to be very, very careful and cautious using our words because there I cannot see a person. So, how and based on the previous conversations you have with the patient, you decide how slowly you are going to break the news, or how are you going to talk about it, how are you going to make a you can say a little bit story and then reveal, or you want it to reveal directly. It depends upon individual to individual, family to family. Understanding and making the interpretation of the report in context of the family history, and approaching close family members for pathogenic, glycopathogenic, or variant testing, any kind of. This is also important. Like while you do a post-test counseling, you just go back to the pedigree which you have drawn for the family, and then you tell them that this individual will require any kind of variant testing based on your report if they comes out to be positive. If they are negative, then you have to explain them that uh, it cover the limitation, like only this many numbers of genes are covered in this technology. There are probable certain genes apart from these genes which are covered in the test can be associated. You can undergo the testing or not can be decided by the clinician, treating clinician, as well as the patient himself or herself. Avoid over information sharing in telegenetic setup, because in telegenetic setup what people do is generally listen to us, understand, and they start googling each and everything. So they will come up with certain novel in the other format that I have got something like this, and you say that this is not relevant. Lots of unsolicited advice that Google and the other portal gives you in terms of medicine is really not required when the any individual is having anxiety or stressful situation in his or her condition of the disease. Inheritance risk should be clearly explained. You have to be very clear with heterozygous, homozygous inheritance. Okay, what is the probability of inheritance? Whether this is a somatic gene, will this somatic gene be inherited? Why somatic genes are not inherited? That has to be explained because they are not so much aware about it. VUS report understanding with risk stratification to do or not. Like there are certain genes which are reported as variant of unknown significance. Then what is, like, will you need a further risk stratification? That is depending upon what is the cancer history in the family members, what type of cancer patient is suffering, whether the asymptomatic as well as a symptomatic individual is tested or not has to be considered, and then given out whether you are going for further variant calling in that particular family or not. Clear demarcation on clinical implication in terms of positive or negative report, which I've clearly explained, that you have to be very clear what a positive report states, you have to be very clear what a negative report states. Potential therapy versus off-label therapy and clinical trial explanation. Okay, we have to explain that on based of certain genetic mutations, this particular targeted therapy will be useful and beneficial in your case. If we are checking simultaneously out for the chemotherapy resistance, also we have to explain that despite being this mutation, you will have resistance because of certain genetic makeup which is present, or you can have certain toxicity, which helps clinician to decide upon what therapy to be used and what combination and dosing will work in that patient. That has to be explained to patient as well, because sometimes what happens, doctor sees the report and uses the certain drug, and then patient will come to us that ma'am ye drug likha tha, ye use nahi kar rahe hain. So explaining them about resistance of the any resistance because of any kind of mutation, or what are the targeted therapy and why it will fail has to be explained very clearly. Now, clear explanation. This you might, everyone might be aware of, like what your genetic report says, like how a common genetic report comes out. So, these are the most three factors, like positive है तो pathogenic है, likely pathogenic है, their classification, their variant description, protein coding change जो भी available है, hetero है, homo है, dominant है, recessive है. Okay, you have to explain that. Negative hai, it is non-pathogenic variant, so this report does not cover any kind of potential mutation which are present in that particular panel or a single gene, whatever. Variant of unknown unknown significance, what is the inheritance, and how this variant of unknown significance is clinically correlated with the data which we have available, like the US hai. So in what segment of data it says, like whether it is susceptibility to cancer or increase in the malignancy or related in the individuals present with certain kind of cancers, is it related with leaf romini, everything it is stated in the report. We just need to explain them and how it is related. Then comes a very crucial cases which we face most commonly in the cancer clinic is like, will my child get a cancer? And can I get a test for my 5-year-old, 12-year-old, 20-year-old? Okay, so how do you decide upon pediatric cases? Firstly, we do not advise any kind of genetic testing in children under 18 years of age unless any malignancy is indicated. For example, if there is any AML or CML case, or if there is any sarcoma case at a very early age, under 10 or under 12 years old, then we allow them to go for the genetic testing, unless not. And it has to be consensually followed by the consents from the parents, okay, before collecting their samples and all. In Indian scenario, this is not much counted because parents and husbands and fathers only decide on what to do the test, and they don't involve children despite being an adult also. But this is how it works. Now, asymptomatic children with pathogenic mutations in affected family members are not supposed to be tested under 18 years. There are certain people who will be like, "Nahi, my child is 12-year old, aap check kar lo na, please." No, we don't have any potential systemic guidelines for screening for an asymptomatic person with a pathogenic mutation as a carrier. That is why the testing is not allowed. The psychological impact of the genetic reports on the children is very different, and you are not able to always gauge out what is running in child's mind. So it, and the child obviously is not able to give the consent, so it is mostly not done, and it should not be. You can say promoted also. There will be certain doctors like, what will it make any difference if the person is testing at 12 or 21? Then you have to make them understand about the psychological concept or the impact of that reports on a child's mind, and then suggest them not to go further. Counseling is mandatory for adults in a private or a family setup. You have to be very much sure about that. If any infant is tested, the counseling has to be done to the family or the entire family, if based on what genetic reports you get. Without counseling, no pediatric cases should go further for any kind of therapy or follow-up testing. Proper post management should be advised, inclusive of screening and age to initiate it. Like if I'm testing an 18-year-old individual female for any kind of potential pathogenic high variant for any, for example, hereditary breast and ovarian cancer, then post reports, I have to make her understand that based on her clinical history and age of onset of first member and the diagnosis age, what are the age limit from where she can start with the basic screening of pelvic USG or self breast examination or clinical breast examination or a simple mammogram, and what should be the duration in an asymptomatic individual, what are the symptoms you need to be taken care of, which has to be explained properly. And if mandatory, documentation of information is very much necessary, because they are infant cases or 18-year-old. If any person is getting testing at 18-year-old, by 25, 26-year-old, the patient will forget what the counseling has done or what counseling has been given to them. So documentation of such, like on papers, or you can just put an email and ask family members or the doctors to just get a printout and put it in their medical file, will also work, but documentation becomes very much necessary. Recommendation for appropriate genetic test. Now when you are dealing with the pediatric cases, it should not be a trial and error. अगर ये नहीं कर रहे तो इसके बाद ये कर सकते हैं. You should be very precise with what test you are ordering. Explain possible scenarios and outcomes. Okay, again, now if something comes out to be negative, parents are very much involved or associated with the child, and in Indian setups they are not ready to just leave off that something can happen to their child. So in that case, before taking the testing, explain all the scenarios. Okay, sir, ये होगा तो ये हो जाएगा, ये होगा तो this we can do, if this comes up we will go with this particular thing and go with this testing. The clarification in pediatric casing is much more necessary than in the adult casing, because explanation and the counseling is much more complicated in such case where the child is involved. Now, how genetic counselor helps the family. Here, I will explain you on case to case basis. Like provide the education. Here, I have a case of a 40-year-old female with carcinoma of breast stage 4 who has come to the death. And I have been subjected to the counseling of the female's husband who is left behind by a single 8-year-old daughter. And he is literally very much anxious and you can say stressed out about a daughter having same condition when she grows up. Okay, and there is no significant family history in this about hereditary breast ovarian or any kind of cancer. And the person comes to me and like, ma'am, I want to get my 8-year-old daughter tested. Then we have to educate them that what are the genes. Okay, if this gene inheritance is, how much is it applicable in her child, what are the chances of inheritance, what is an ideal age. So we educate them on genetic testing, its aspect and its implication in a child. So we provide education during our counseling session in such phases. Then comes the session of risk assessment. Here is a case of 67-year-old male with recurrent pancreatic adenocarcinoma who was found to be positive for RAD52, a heterozygous gene mutation. This 67-year-old individual has four siblings, okay, and two children. Now we have to help them get a risk assessment because this is a germline positive mutation. The sibling testing, why it is important. हो सकता है आपके parents में होगा पर disease manifest नहीं हुआ है because of less of expressivity. Why your sibling needs to be tested? What are the chances your siblings will inherit this mutation? Why testing is important in the children. So here the risk assessment stratification I am explaining them. For this particular case, we did a risk assessment. It is still going on, like where I'm working. Four siblings have been tested. Out of them, two siblings are positive for RAD52 mutation. Both the children are positive for RAD52 mutation. And now we are testing for the children of the other two affected siblings for further risk management and surveillance strategy implications. So that is how you help them assess the risk. क्या chances है, क्यों होगा, किस लिए होगा, why it is important, all that has to be made understood to them. Second is support and educate. Now, here is a 25-year-old female. She is an asymptomatic person with a BRCA positive mutation in the sister who was affected with breast cancer at an early age of 35 years. And the mother was also affected with breast cancer at age of 37 years and passed away because of cancer. Now, this female is carrier of a BRCA positive mutation also, along with her sister. This counseling setup was done in a family setup where father and two daughters were present and where the inheritance about BRCA mutation and its clinical implication, early surveillance, possible risk reduction surgeries, everything was explained. Now, here I educated her on risk reduction surgeries. She was interested in getting that done despite being a single female, uh, not yet married, and without thinking about further family planning. She was like, no, I want to go risk reduction surgeries because I have seen my mother as well as my sister going through all this. So we need to support her decision. Okay, but we live in a social scenario where she is taking that distance instantly that no, I will go for risk reduction surgery, I want to go for complete mastectomy and complete oophorectomy, I don't want the risk at all. Genuinely she was scared because she has seen the patients in the family. Here we educate her that risk reduction surgeries के post surgical aftermaths क्या होते हैं, how are you going to deal with it psychologically, physically and socially. Okay, we need to even you can say educate the family to support her. Okay, we should not say that you should not go for a risk reduction surgery because you are a 25-year-old unmarried female. No, it is her decision as an adult to take or make a choice for safety and benefit of her health. So we need to support her, but simultaneously being in a non-directive approach, we also need to tell her that this can be the implication and you have to be prepared for that, or we need to prepare her for that after taking the regular follow-up sessions. Next is the phase of facilitate the decision making. Okay, now here is a case of a 64-year-old female who was affected with CA breast with no significant family history, and she's under the medical management for the chemotherapy and radiation. She is having a three children. Okay, all are 21-year-old plus. And when a germline testing was done for her, considering her age and no family history, we found two mutations to be positive, that is AXN2 and PTCH. They were reported as VUS. And now the children's were like, we want to also undergo the test for this particular variant. Now you have to assist them in their decision making, that VUS hai, so what are the possible outcomes of a VUS report. Okay, they were under the pretext that if I'm going to get myself tested for this mutation, I will get a conclusion that I have this mutation or am I at a risk. But VUS is a non conclusive report in itself. So we need to guide them that, if you are going to do this test, you will not be sure. Okay, are supposed to get this as a VUS only. Just it will tell you whether it is present in you or not, but it will not define any further medical management or surveillance in your healthcare, because this result itself are insignificant in the clinical etiology of cancer. So we have to facilitate the decision making, because this in this scenario it was just a blind decision that, I also want to get the tested and my siblings will also get tested because my mother has been found two mutations in that, and they were under the belief that, if you don't have the data, but this is the only reason my mother got the cancer. So we have to guide them and facilitate. We don't have to tell that no sir, you cannot go the testing, but the potential, the pathway of making them understand about the outcome of the report, and how it is going to be helpful or not helpful has to be conveyed easily. Now, after the helping comes the core element of the consent. Now, dealing with patient. Okay, what are the consensual elements which we really need to focus is the type of the possible results. Explaining them, getting a clarity is very much important. Somatic versus germline setup has to be explained very clearly so that patients are not clueless after getting the test done or giving the samples and helpless after the report comes out. Secondary findings, very much important. Like certain cases, people where the we are not able to find any definitive mutation pertaining to therapy or something, they go for the clinical exome or whole genome kind of thing. Now you have to make them aware what are the potential secondary findings which are not related with the cancer, but you will be finding it, and how are you going to deal with it. So that is again a very different and a long conversation of counseling with the patients. Reanalysis data, how is the data going to be shared, reanalysis, what is the cost of the test, and everything has to be made very clear. Other post test report generation. Now sometimes people think that genetic testing करा रहे हैं तो एक बार ही कराना है, we don't need any other test. So you have to make clear what that particular test is done for, what will be covered and what not. Will you require any post test after this genetic testing? Any serum based test, blood based test will be needed for the follow up. Test has to be understood and it should be consensual from the patient. It should not be like नहीं मैंने आपको बताया था पर patient was like नहीं नहीं I don't know about that. So mostly all these things are, written and documented, and consent signing becomes very much important when we are doing a test. Last but not least is testing in the family members and the cost involved. Because see, when you are in the Indian setup of the cancer clinic, the treatment also comes with the cost of the health as well as the money. So why while you are testing in the family members, it becomes important to reveal the cost to them, because at that point of time they might not be affording or they will need a financial assistance for doing it, and you should not be adamant like abhi ke abhi karana hai. You should give them some time that okay, this is generally for screening for family members. So once you are in a stable economic position or a stable situation mentally as well as economically, then you can uptake the test. That has to be made them understand, because most time what happens when we say family testing is needed, the families get alarm. Oh my god, new costing is involved, now I have to spend more on just testing it. So that has to be made very clear, and it has to be consensual with the patients. You should not leave patient out with any information possible. And mostly all these things are documented. Some people do, some people don't, but documentation of this core elements of consent in setup is very much important. Now, counseling issues, what are common in telegenetics or clinic? This is a total overall, you can say, after the entire process of counseling is like psychological need of patients and their family. It differs from individual to individual. Okay, some people are okay with the report, some people become angry, some people harbor lots of guilt and anxiety and stressful. So it depends on individual to individual. Non-directiveness is much. You should not be involved in directing any of the decision uh, of getting the testing or in any of the process of genetic counseling. It should be a non-directive process. Translational analysis model for patient benefits. Sometimes when the patient gets information, they become very low, or they feel like they blame their luck most of the time, that I am the unlucky, and they feel down, which is not so good. You have to get them back to the track and make them feel okay with continuous sessions, supports, calling, checking them up on regular basis, because it affects their mental health a lot and they might do something wrong in most cases. So that kind of follow up should be necessary. Continuous touch with them is necessary. Educating them that you can do it, you can come out as a survivor, this is the common thing, and you cannot be just like succumb to the disease, or be a recessive to the disease. You have to motivate them to keep going in the entire process. Advice giving approach is big no. Okay, you don't use the words like, okay, I'm advising you. Will not read such words in any of the genetic reports that this particular thing is advised. Okay, advice, no advice giving. You have to be very transparent and clear and crisp with what information you are sharing. Privacy protection. Certain cases where family members don't want to get their extended families involved, or couples don't want to get their in-laws or parents involved, that has to be asked beforehand, before sharing out any information on any email, phone call to any member. You are not just going to call up and say that, are you talking some relative, I want to discuss about this. And if the patient asks from them like, नहीं नहीं हम relative है आप बता दो, no, that is a big no unless you get your relative and unless you get a patient on call and he gives verbal or written consent. Timely counseling supervision. Now this is the thing which is involved the counselors themselves, okay, and not the patients. Like, see, when we are in a certain kind of setup, we have got, or we just mold ourselves to that particular role. So timely supervision of our counseling is also very important. That whether I'm going something wrong, or I'm diverting on certain path, or going in that particular systematic manner only, that has to be checked timely. Some seniors or your co-counselors can also work. Like in certain cases, when you're working on a counseling, you get another counselor sitting with you, and you just ask them to keep mum and monitor the entire process, and then after the counseling you just point out that what did I did wrong. So that is for the important for counselors growth as well as counselors mental health, because dealing with the cancer patients and clinics regular basis, it's really stressing in for the mental health. Now, this is the last slide where I will just put up what are the challenges for counselor in the Indian setup mostly. Okay, like number of patients versus counselor. We have very less number of counselors and lots of patients increasing day by day. Lack of awareness to avail genetic counseling services. Some people are not even aware that they can use genetic counseling services for understanding, explanations, and talking out, and they can be a part of their entire diagnosis to treatment process. Database pertaining to Indian cancer cases. Like when we come across the database, the data we have for Indian cancers, the variants, the interpretation, the relativity in certain kind of cancers is lesser in comparison to Caucasian and European population. Most important, genetic counseling clinics in the cancer or multi-specialty hospital, we are still not sufficient with the genetic counseling clinic setup. That is the most challenging part of cancer diagnosis in India. Availability of counseling services in rural or tier 3 cities. In rural approach, counselors, you don't even get doctors, counselors are out of question only. So we need to set up counseling services then, because most of the cases comes from the rural area. They are not even aware about what cancer it is and how it affects their daily life and their family members. Timely counseling due to lack of funds. Also, counseling comes with a cost. Some people give it at free of cost. That is why most of the counselors in our setup works for NGO who can, give counseling services to the patient on timely basis, because not most people will have the fund to spend on services like counseling, where in our economic stature the counselings are not given free of cost. Recognition as a part of core oncology workflow. Genetic counselors in India still struggle to qualify themselves as a part of oncology network mandatory for the patient care. By, I would not like to say the institutions, but the government bodies or the private setups, it is very difficult for a recognition of counselor. You have to give a lot of explanations what you do, and you have to testify your individuality every time. Training and workshop for continuous knowledge and education. Not much workshops are available for genetic counseling trainings. Okay, we also need learning and training style. We realize that as a counselors, there are very lesser efforts from any of the bodies pan India. So that's my time, and thank you so much for listening patiently. And now I would like, if you want to discuss something or have any questions on what I have presented, you are all open to ask.
Yeah, Ruchi, I mean, it was such a wonderful talk, right from the applications, what is the importance of a genetic counseling, and how it should be implemented in and across India, especially, and the major challenges that you have discussed. Yes, I mean, India is far beyond that because there's a huge gap across the basic science and to implement it on the bedside, on the translational bedside. So here we are lacking, there is a huge gap now. So my I have one question. It is like, what do you think, I mean, based on each cancer types, how genetic counseling can prevent, at least can prevent to some extent, from getting, diagnosed with cancer. I mean, you can take any example, specific example of any cancer, if you have, in your point of view, what do you think, how much, to what extent it can actually prevent?
Okay, so the thing is about the screening testing is like screening will give you an insight, where it has been started. For example, if any person is undergoing a mammography regularly, it becomes easier every annual mammography. It becomes easier to spot a lesion, okay, rather than a person who is maintaining a healthy lifestyle or anything and everything, but not to at all doing any kind of screening out of fear, or maybe out of the question that I don't need it because it's not in my family or something like that. So screening test becomes very much important, because they will give you insight on what is there inside your body. You are not feeling the pain, you are not feeling the lump, you are healthy, you are maintaining the weight, you are eating healthy, you are not having any kind of bad habit, but you do not know when it can originate. So screening test becomes important. For example, in the cases of colon cancers, if you can say, okay, not everyone will undergo colonoscopy because obviously clinically indicated nahi hai. So what we need to do is we need to tell them that you are having IBS kind of condition. Are you facing the frequent weight loss situations? Okay, or are you having issues with blood in the stool, not frequently but sometimes? What is the condition? We need to ask them, we need to correlate with their routine problems, and then it becomes like, no, this is related to something, you can undergo this. Okay, if certain person has PSA values, okay, high, and it's like just because nahi, thoda sa hi high hai and it is maintained, why? You need to take an action. So the screening tools are very much important, because physically aap kitne bhi fit ho, okay, unless you do the screening, it is not revealing what is going inside the body. And see, Indrani, what is the main problem with the Indian healthcare system is like, or not healthcare system, I can say Indian individuals. Okay, unless you feel an extreme pain and trouble in your routine, you are not going to visit a doctor, out of the fear, because if you land in the hospital, the bills, what if something goes wrong, what if something bad happens to me? All that stigma is also attached with not going to doctor. So most of the time people don't even go.
True, true. Very well
Important.
said. Because
है
I
ना?
mean that is, I mean the one challenge that you have mentioned in the your presentation I saw, because it's a lack of awareness. Many of them are not at all aware what is genetic counseling at all in many of the metropolitan cities
Hmm.
itself. So rural areas are far away beyond that. In urban areas itself, people are not much aware of these things, and in major
Exactly.
hospitals also they are lacking this thing, because I mean, if we consider not only in case of cancer, some other any kind of genetic diseases, for example, thalassemia.
Hmm.
In West Bengal, actually, where I did my graduation, so that was the only one
Hmm.
college within West Bengal where there used to be regular doctor checkup. So my college
Hmm.
principal and and his wife, they used to do regular health checkup for thalassemia patients. They regularly used to
Hmm.
do this genetic screening. Otherwise, and all people, I mean, one and across there is a total huge gap across. So I mean, what you have pointed out, it's a very very I mean very crucial point actually. Yeah, and yeah, participants, other questions please you can ask. And wonderful talk, Ruchi. Seriously, it was
Thank you
awesome,
so
awesome.
much.
It was awesome.
Yeah, it's really wonderful, Ruchiram. Actually, I feel like maybe sometimes it is very important that all the researchers should always try to coordinate with some kind of organizations where the health camps can be done, and also maybe some kind of government like initiatives are also required where people don't feel that why we have to, like I have seen lot of people, they think that if we are fit, why we have to go for a normal screening, so they
Yes.
just ignore it. So that is the
Yes.
ignorance itself is a big challenge to make them understand that every 6 months or every 3 months a regular checkup on health is all must for everyone. So I think
Yes.
that is really good, and I really appreciate the initiatives you are taking and the motivating awareness, yeah, programs. And please let us know if we can also be part of that. We will be happy to
As
be part of
yes,
that.
as a researcher, I would like to tell you that please get involved in the translational researches. Okay, I know this country is much affected with the bacterial, microbial, and virological research, but we need researchers to be more proactive in oncologies and pediatrics and metabolics. We already are on quite a good path, but for oncology, we don't have anything. Because if you want the country to establish its own database, I want the researchers to work on that. Working on a virology or toxicity is not going to help in the terms of diagnosis and change in the healthcare system, but working on oncology, and I know it's a very costly affair, it is not like I'm suggesting and someone is going to do, but please try to focus, because at this point of time it is very much important as an input from researchers, basically. Okay, to put pour that thought, because they will be seeing a lot more in the micro levels, or you can say the genetic level, than what me as a counselor will see in an individual. So translational research promotion in the country, getting the funds, we should be also writing to government, like, approve such projects where it involves the studies which are beneficial for the patient, in which the country is currently dealing with, rather than
Exactly.
some super virtual things what we do.
No, the basic thing what I feel is, in most of the
Hmm.
cases in India, we get stuck up with the ethical issues. I mean,
Yes.
because for example, I'll just take a very small example. When we do a simple drug testing in the animals itself, when the
Hmm.
ethical committee comes, if they hear, say for a number of compounds, a group of researchers wants to test, they get panicked by the
Hmm.
hearing the number of rats they are going to sacrifice. Okay,
Ah,
so
yes.
this is very very prominent in most of the institutions. So I mean, we have to consider in such a manner that, yeah, we cannot blame the ethical committee purely, because their point of view is also true. We cannot go on killing the animals also. We
Yes.
cannot sacrifice someone's lives, but there should be a rational balance drawn out, the way it is
Yes.
going to help out as a therapeutic outcome for the cancer patients, and definitely it will enhance. it will enhance our research level, and it should be translated. Definitely it should be on the translational level. So yeah, this is
We
very
should
very important.
see. What I feel is like we also lack the clinical trials. Come on,
Definitely,
the
definitely.
pharmaceuticals are. We should encourage. See, we have lots of cases. Lung cancer, we are at second number.
Yeah,
Okay, in the lung cancer cases, then why don't we start a clinical trial? Why don't we have
exactly.
clinical trial in the cases?
You know,
Because see,
voluntary, and
uh,
then that will involve voluntary
hmm,
involvement of the human beings also. So I mean, lot
yes.
of things, and then
And we have that resource. See,
yes,
we have that voluntary resources also, okay, who are like ready to participate in that, because they don't have anything to lose. All they have with a clinical trial is a hope that, nahi,
exactly.
something good will happen to me, and that is why it is must. Like, we
True,
should
true,
encourage
true.
of more clinical trials in the country along with pharma tie-ups.
Very well said. Actually, few months back, the compound. I don't exactly remember the compound name that was tried in USA, and it is effectively able to
Yes,
cure
but
cancer. Just it
yes,
was a
yes,
pilot study. At least they have tried out on a pilot study. So this kind of, at least if
yes.
not fully, a pilot study can will definitely help us to get an overview. Okay, fine. At least it is working on for
Hmm.
colorectal cancer or this particular cancer
Yes,
type.
yes,
So then we can get
exactly.
that courage to make it over in a national level. Okay, if not six, if not 80%, at least for 30% patients can survive with this particular drug. Yeah, and we have to
Yes,
consider the side effect and the
all that
side
18
effects.
people, okay, who were there in that antibody trial, okay,
Exactly,
they
exactly.
went in the trial with that
Trial,
hope, okay,
exactly.
like, okay, and then they came out victorious miraculously, and
True,
they were
true.
like, that
Yeah,
created a hope for a lot other people to get enrolled. Now they will be doing a study on a very larger level, which
larger
is very
population.
much good.
Yeah, yeah. True, true. I mean, that kind of thing is lacking in India. We should have that initiative,
Mm.
and that should come up from the government level, that they should impose it. Unless and
Exactly.
otherwise, they don't make it as an as a compulsory. We, in spite of we write a proposals or project proposals, I'm saying it will be getting rejected.
Yes,
It will be definitely getting
obviously.
rejected.
It should be initiated by government, okay?
Yeah. Yeah. Please, participants, if you have any other questions, please feel free to ask
Hmm.
here.
Yeah, if, may I ask a question, Indrani? Yeah,
Yes,
Sure.
sir. Yes, sir. Please, please,
yeah,
please.
yeah. Ruchi, thank you so much, for enlightening us. It was an excellent talk. Yeah, Ruchi, I'm sorry, I missed your talk in between, but I have a very,
Hmm.
naive question. We follow ACMG and AMP guidelines, but
Hmm.
seldom, we look into the Sherlock guidelines now that has been promulgated over the last, 2 3
Hmm.
years. So where are we heading, in terms of genetic counseling of rare diseases, applying the Sherlock guidelines? Where are we now? Are these promulgated? Are these being, dealt anywhere?
They are okay. We have the guidelines, but for all like for rare disorders, yes, we do have good guidelines and people follow. But the only thing is like it is limited to the again like the population studies on which the guideline has been made are more likely for the Caucasians and Europeans. Okay, so what we have to do is. I mean, related genotypically and phenotypically with the family history, and yes, we adapt from the guideline testing and everything is done based on that only, but more genotypic phenotypic correlation is required in rare genetic cases rather than going only by the guidelines. See, because I'll give you one example. Okay, for the like in guidelines suggest for any kind of alpha thalassemia or beta thalassemia testing, a PCR with an MLPA technique is an advised case. Okay, but how accurate is this PCR? Now, when I test the samples of the PCR from an Indian population and a Nepal population, okay, same age, same individual, same kind of HPLC, I do not get a report in a Nepal population and I get in India. So the guidelines are most generalized. I want like PCR, what PCR? See, there are the variants. So limitation of technology also comes out in the guideline here. So we resort to the other people like, okay, fine. Now I have this situation. Now what should I do? So there is lot of back and forth going despite following the guideline also, and we miss out a lot in between. Like starting from the diagnosis to the counseling to the till the patient is given proper kind of medication, we have missed out quite a lot. And guideline, yes, are helpful, but not that much, because not based on our scenarios.
No, I understand. Yeah, I mean, especially moving towards a rare disease spectrum. So let's assume, these Sherlock guidelines need to be emphasized. If we really don't have a good pedigree information,
Yes.
or even if they are say autosomal recessive condition, and so let's assume we don't have a kind of a try or a quad based cohort
Yes.
associated with
Yes.
that particular case.
Oh.
So are there, I mean, what I'm just not trying to understand is, because
Hmm.
I work on rare diseases. We
Yes.
have at least analyzed at least 400
Yes.
to 600 exomes, out of which 200 are rare
Yes.
diseases.
Yes.
So
Hmm.
what is the institutional or best practice per se, if we were to take the Sherlock guidelines to the next level? I don't see this probably
Hmm.
happening. We're only probably ending up the story looking into the ACMG validation or ACMG
Hmm.
classification,
Hmm.
then moving ahead. Are there any instances apart from the knowledge or example that you have described in terms of
I
any say
think
gorgeous or yeah.
for rare diseases condition, okay, the most important thing is study on the micro population and ethnicity specific. Okay, segregation based on ethnicity is very much important when it comes to designing the guideline, and it has to be a more this rare genetic disorders are more related to ethnicity, so country wise there should be a guideline. We have like you are working for rare genetic disorders, so you might be aware about organization of rare genetic diseases, okay. And they have come up with an excellent workup or write up, and they are doing contributing a lot. Like we get the guidelines, agar ye condition hai, it is found in this particular population, in Indians, in Asians, so we get to relate correlate. So country wise guidelines for rare genetic disorders is must, and it should be guided or overviewed yearly or maybe 2 yearly by medical, molecular, and government committees, because from every aspect development is important, right from prescribing a test to understanding the ethnicity to social, ethical, and financial situation for such conditions has to be needed. So yes, we need a ethnicity specific guidelines and a country based most commonly.
Right. Yeah. Thank you so much, Ruchi. Yeah. Thank you, Nayaz, Sugu, and Indrani, for the wonderful organization. Amazing. Yeah. Thank you. I'll stay in touch with you, Ruchi. Thank you so much. Yeah.
Absolutely.
Yeah, Ruchi, this side, Dr. M. K. Nyas.
Yes.
Yeah, thank you so much for accepting, our invitation, and I really enjoy the entire presentation, to be honest. And this, I mean, the last slide that you presented, that was like absolutely that what we are looking ahead also,
Yes.
in terms of awareness, or in terms of, the bridging the gap between clinician, and the families, or you can say any common people whom, genetic counseling is required. At the same time, we are also trying to connect genetic counselors, experienced genetic counselors like you, in various area, like communicable, non-communicable disease as well, rare disease, of course, as shared by Prashant.
Yes.
So this GCCI is it's just a baby stage, and we aspire to write good project actually, where
Yes.
we can answer some of the problem that is still in the society, and if you want to eliminate from the society level, we need some really good grant or fund to support the entire concept actually. I just wanted to know from your side, because in your introduction you said, uh, uh, Prashant, can you mute yourself, please? So,
Yes, sir.
Prashant, can you mute yourself, please?
Yeah. 1 minute. I'm really sorry for this. I'm really sorry. 1 minute. Yeah. I'm not
Yeah,
able
yeah,
to do
sure.
that.
Please. Okay. So, you rightly said that you're also working closely with the NGO,
Yes.
where if someone is not like willing to afford the cost mainly in the oncology
Hmm.
area, but still you are supporting them, at a various level. So our
Yes.
foundation, Abir Bioservices Foundation, is aspire to help those, group of families from any community from pan India level.
Hmm.
We also trying to raise some fund through different mode actually, and
Okay.
we wanted to help those group of families as well. So
Hmm.
what we need a diagnostic lab to test that report. If some test is really expensive,
Hmm.
we are willing to support those tests as well on the behalf of our foundation. And
Yes.
AB Bioservices Foundation is closely working with Bioclues with the help of Prashant. And
Hmm.
we have very experienced genetic counselor with us. Probably you know that lady. She was with us, Dr. Dhanlakshmi Shetty.
Yes.
And under her guidance, so we are framing some concept, some proposal to raise some more fund with the help of some funding agency as well. So,
Hmm.
how do you feel like where we can connect in terms of laboratory support? We really want to know more, from your how you're working for those group, those who are underprivileged, you can say, and we wanted to uplift them as well. Why why they are like so under rated or under screened, or they're not really aware of what is going on, what is happening around them actually. So, what is your call on that? How can we
Uh,
work together as a team?
See, in the terms of laboratory services, yes, for the people who cannot afford, we can try giving test at cost to cost basis, okay, or at least the NGO with whom they are working, they can bear the 50% of cost, 50% the laboratory can base, and we can work in such kind of setups. Counseling obviously will be free of cost, okay. You have the counselor, me and my teammate are also available for that. Okay, it would require more of a, you can say, uh, co-working or co-approach kind of thing, like how and in what scenarios we can give the test, okay, where we can give regular camp at least just for the awareness and doing the basic biochemical checkups can also be done, okay,
Mhm,
which is really good. And then we can take it, like I have an entire team who can help you in facilitating such
mhm.
kind of provisions, and I would be
Okay,
glad to
okay.
connect them with you.
Yeah, that's wonderful, wonderful. Yeah.
Mm.
And as a personal front, let's say if some voluntary services is required to
Hmm.
to give any free consultation or counseling, not obviously not everyone, but yes, someone
Hmm.
who is really needy actually, and our
Hmm.
socioeconomic condition is not really good. So at
Hmm.
personal front, what's your commitment towards serving the community? Are you like ready to serve them as well? Not
I'm
only on the
already,
testing part, but yes,
no, no,
at
not
the
on the
counseling part.
testing part.
Yes,
In
yes, yes.
part of counseling, in part of talks, yes, I do a regular awareness camp in collaboration with one
Mm-hmm,
doctor here out in Pune. I also
mm-hmm,
give them counseling services or any consultations, and there are like certain tie-ups with them. I do it like I don't even consider what is the cost of it, like by doing the counseling,
right.
and that is the
Mm-hmm,
part of the noble work that I do, and I'm open for them. For a limited period of time actually, because right
mm-hmm.
now I am also occupied with so much work, but I do make sure that
True.
2 weekends or something, I just give
Mm-hmm.
time and dedicate some hours of my day for working them when I am actually not working in corporate. So that's what how I
Okay.
do. We
So,
also have like my father is a member of Red Cross Society, so whenever
mm-hmm,
necessary and I need counselings or I need to give
mm-hmm,
counselings or someone needs it, they just refer it to me and I don't even bother to ask about the consultation
mm-hmm,
charges. Okay.
mm-hmm,
So, when you say considering a counselor serving the community, it will not be me. It will be any counselor who is present in the setup, in the Indian setup actually, is always
mm-hmm,
ready to help because they know that the need of an hour is the counseling and people need it.
mm-hmm. Okay,
So,
so
not everyone is, willing to. You will get a lot of counselors who will be contributing to the NGO work always, and they will never tell you no.
uh, yes, we have good number of clinician, on our foundation as well. Those who are associated with us for more than a decade now, you know. So they are
Hmm.
also giving on and off counseling session related, not genetic counseling, but yes, a lot of counseling is required related to different diseases that is, you know, common in women and girls. Because our
Hmm.
foundation is totally focused on women and girls health related issues,
Okay.
and one of the area that you can say my area of expertise is cervical cancer, that is
Hmm.
very common in Indian population, and you know, counseling is also required in that area.
Hmm.
You know, because it's STI and common virus HPV
Hmm.
is the main positive agent, you know, and due to there are a lot of myth wherever there is STI, there are a lot of myth and stigma
Hmm.
in the society, you know. So we do a lot of free counseling to the couples, you know, if someone is
Hmm.
infected and what to do next, you know, and we have all the treatment option with us right now according to WHO
Okay.
guideline. We have a vaccine. We have a lot of screening tools, and core is really, you know, doing really great job in screening of this HPV, you know, through DNA testing or Pap smear or liquid-based cytology. They have full panel of tests for this particular, you know, cancer screening as well. Do you have any experience in your career so far where couple come, you know, for this sort of counseling related to cervical cancer or HPV infected cases
Not exactly
so far?
cervical cancer, but I do have experience of doing couple counseling. So
Okay,
yes, I
okay.
know how much stigma is attached and how much
Hmm,
beliefs
hmm,
and you know
hmm,
the
hmm,
social and the privacy is involved in such kind of
hmm.
cases.
Yeah, I mean, I just this is just for the audience knowledge. You'll be surprised to
Hmm.
know that we are losing almost, you know, one woman in on average 7 to 8 minutes as per ICMR data before pandemic,
Hmm.
because of this particular viral infection, you know, HPV related cervical cancer.
Hmm.
So I
Hmm.
think a lot of WHO guideline, you know, come up with this, you know, so counseling is one of the important aspect uh,
Hmm.
for the management of this particular disease as well. So probably I'll discuss offline on this part because we are doing a lot of activities
Hmm.
to manage this particular cancer and prevent this particular cancer, you know. So
Yes.
probably I'll take your help to, you know, plan some blueprint and let's see how we're going to reach the community and, you know, make them aware how to get rid
Hmm.
of this particular disease from the community. So there are a lot need to do, to be honest. And
Yes.
at the last question you can say from my side is,
Hmm.
I think you are based in core diagnostic in Gurgaon,
Hmm.
right?
Yes.
So what is your experience with North Indian population? Because probably you'll get more exposed to those,
Hmm.
counseling with them actually, rather than we know that it's very well established program in South India. A
Hmm.
lot of institutions are there, a lot of genetic counselors are there. They really don't want to
Hmm.
move to the north because of, you know, their uh, comfort zone in that particular region itself. Because
No,
we
not
have seen their,
moving to see,
yeah.
not moving to north is not based on the comfort zone. It is more of a. It is not like you don't have options because they are
Okay.
from South India and they are more tech customized. And
Yeah.
the frankly speaking, the diagnostic companies more reside in Bangalore, Hyderabad,
Hmm, hmm,
Chennai,
hmm,
and
hmm,
you
hmm,
can say Bombay rather than having it in the north. Okay, so it is not
hmm,
like based on the experience in living in north. Yes, the cost of living and the concern main is the security and privacy, and that's the reason
hmm,
they are a little bit reluctant to move to the
hmm,
north. But let's, there are lots of
hmm,
opportunity. We have the counselors from pan India working for every
hmm,
like company. But yes, the
hmm.
establishment of the genetic counseling, genetic testing and molecular biology is more strong in south India than in the north, but you cannot
Yes,
deny
yes.
that it is not growing.
Hmm,
uh, like
hmm.
you have the best lab for doing any kind of genetic testing right here in the heart of Delhi, Gangaram. You cannot
Hmm,
deny the
hmm,
fact. You know, you have the
hmm.
main establishment out here. You have lots of hospitals and lots of patient flow in places like AIMS. AIMS has been in everywhere.
Hmm,
Most of the AIMS you will be
hmm.
finding North Indian region, north, west है, के north east है, you will find AIMS
Yes,
everywhere. So the reach out
yeah.
is there. The preference, yes, it is different a bit. So
Yes,
like availability of counselors are more in south than in north. That is the
yeah.
only
I
main.
mean, as per our last experience from our previous, you know, speaker from Kaminami Hospital, you know, Dr. Annie
Yeah, Dr.
Hassan,
Annie
she
Hassan.
right. she rightly said that as far as supply and demand, there is
Yes.
still lot need to do across the India because it's not uniform. And especially in northern part or eastern part or central part, we do really need lot of genetic counselor, as per demand, right now demand actually,
Yes,
So,
as per the demand,
so
we need the physical. See,
yeah,
it is
yeah,
not every time this counseling will not work. I'm calling you and doing the counseling. Okay, now
yeah.
with the pandemic, we have started adapting that situation, but we need a proper clinic because what is the mindset of a patient is like मैं clinic में जाऊंगा तभी मुझे
Hmm.
कुछ मिलेगा मैं क्लिनिक
Hmm.
में
Hmm.
जाऊंगा
Hmm.
तभी मेरे साथ कुछ हो पाएगा so the
Yes.
belief of Indian people getting that
Hmm.
satisfaction of consultation in clinic is more than in telephonic consultation.
Yes. So we really wanted to, we had a lot of discussion on GCCI
Hmm.
forum also, where we wanted to promote telegenetic counseling, So
Yes.
what is your experience on that part? Because we still, after pandemic, definitely we are more used to this, online sort of things. But
Hmm.
as far as counseling is concerned, what do you think? Is there any acceptance in the society, or still we need to wait for some time and then
widely
really need to be pushed
widely
actually?
accepted widely
Yeah.
accepted.
Okay.
It's
Okay.
been it is
Okay.
not like in the pandemic I'm doing a telegenetic counseling. It's been 4 to 5
Mm,
years I've been doing genetic counseling because as you said the supply and demand not genetic counselors are available everywhere, so we facilitate patient with
mm.
whatever possible option,
Yes.
like as
Yeah.
easy as doing a WhatsApp calling to as complicated
Mm,
as downloading the Zoom and scheduling a meeting. Okay,
mm,
so
mm, mm,
the aim of counseling is not the medium, it is the way
mm.
that patient should be comfortable. अगर मैंने zoom talk
True.
करके I'm not starting a video and patient is uncomfortable, he will tell me कि मैम आप मुझे I mean can someone I mean can I see someone, so that is the affection,
Mm,
okay, about having
mm,
or seeing
mm,
a person one to one. And the pandemic
mm.
has made it very easy to use the telegenetics. Yes, the
Yeah.
satisfaction of patient as well as a counselor doing the setup is not like you can say 100%, but it has definitely reached up to the mark of 80%, like they are happy. And the technology of this telegenetics has got them very close. Okay, I mean quick
Mm,
answer on one call jo approach tha for counseling,
mm,
at least in
mm.
this setup they have made it very much easier. So yes, it is
So
good
I
to
can
have
see,
that.
yeah, I can see the bright future for GCCI because we are really interested to come up with some of, some courses related to genetic counseling as well as promoting genetic counseling in near future actually. So,
Yeah.
so thank you so much for your,
Such wonderful
sharing your
talk. Yeah.
experience as well as your insight. Yeah.
Yes,
And
sir.
Rani,
Yeah, yeah.
you
I
can
just had.
conclude the session. Yeah,
I
please.
had just a small request, sir. Before concluding the session, can we have a photo with ma'am? And sir, can you just take this honor, please? Because in my
Yes. I
laptop.
mean, I'm on phone actually and mid of the way.
Okay.
So I don't think I'll be able to capture the image.
Okay, I'll just
Um,
try if
Okay.
it is possible.
yeah,
In my laptop,
yeah,
the keypad is not working at this point of time.
yeah.
You
I
can
mean,
just do a
it's
print
okay.
screen.
Yeah, that's what, ma'am. That print screen option is not working. So that's why.
Yeah,
Okay, I'll just do it. Okay, just give me a moment.
Yeah, thank you so much, ma'am.
Okay, I have captured. It might not be so nice, but yes,
It's
just give
fine.
me a
Yeah.
moment. Let just a moment. Don't watch everyone. Just off it. Okay, one moment. Okay, I have one. Not so good, but okay, we have it.
Yeah, that's fine, ma'am.
Okay.
Yeah. Thank you so much, ma'am. I mean, really, it was such an inspiring talk and an eye opening session for all of us. And literally, as you said, I think maybe near sir, yeah, I mean, this thing like the counseling can may work over because in northern side, I feel like there is very much less of molecular and diagnostics labs. There is a requirement where this lab should be set up more and more as compared to the south. I myself can find the difference. So yeah, we hope so, looking for the best future ahead. with Ruchi ma'am. It was
Thank,
Thank
really
you.
thank
inspiring.
you,
Thank you.
thank you, Indrani,
Thank you so much,
for
ma'am.
your, it's really you always energetic and engaging.
Thank you, thank you. I do for
So thank you
Bioclues.
for,
Yeah, I really feel that pleasure.
yeah. So
Bioclues has given me that opportunity. That's why I have to
yeah, no,
serve
no,
for
you are.
Bioclues. Thank you, sir. Thank
Thanks,
you so
thanks
much.
for
Thank you.
hosting for today's show also. Yeah,
Yeah,
thank
thank
you
you,
so
sir.
much.
Thank you, sir. Once again. Thank you, everyone.
Yeah, yeah.
Yep.
Thank you.